So the education, I got this from the professional organization which governs the dosimetry, which is called the American Association of Medical Dosimetrists, AAMD for short. And this is the education for medical dosimetry, which is on their website. And it says Medical Dosimetry Certification Board, which is the MDCB, sets standards on eligibility for the certification board exam. Formal educational programs are listed in the JCERT website, which we'll go into in a couple of minutes as soon as my computer decides to work. So formal medical dosimetry educational programs. Some programs require an applicant to be a registered radiation therapist, most of them do, for an individual with a baccalaureate degree with physical science prerequisites. Courses such as biology, physics, calculus, trigonometry, chemistry, anatomy and physiology, computer science, medical terminology, and general health care are examples of typical prerequisites.
I'm not smart enough for that.
The application may be reviewed, be required to interview with the admissions committee and be selected on a competitive basis. Some programs require that a clinical observation be completed in medical dosimetry to ensure the applicant understands the profession and can determine if the profession is a good fit. Applicants should contact the director of medical dosimetry program to which they're applying for information. So what does the dosimetrist do? Those of you who are interested in dosimetry, what does the dosimetrist do?
I'm assuming they figure out the dosage and how it's gonna be in the treatment plan, and I would assume that's what they do.
They work with the physician.
So they do the calculations and
Yeah, they work with the physician the physician gives them a site which they need to have treated. So he will give them, or he or she will give them a site, say prostate, for want of a better thing. He'll say, I want such and such a dose to be given to the prostate. But I don't want the surrounding tissue to have any more than whatever amount he wants to give. It's then up to the dosimetrist to produce a plan using the computer and the computer programs to give the physician a plan which will treat the patient and give the tumor, in this case the prostate, the amount of dose that the dog wants to give without giving an adverse amount to the surrounding tissues. So they're basically at this point in time working with computers. That is basically what the dosimetrist does. They sit in a little office, actually sometimes a big office, depending on how many dosimetrists are, and works on computers most of the time. In some departments, they are also included in the CT planning. They'll go into the CT and help the CT therapists do the CT. In some cases, the dosimetrist does the CT. But in the majority of cases, they have very, very little patient contact. So if you want patient contact, you don't
I was
want
just
to
thinking
wait.
about as I age, where could I go with it? You know, because I am older, so I didn't know whether, really, I love patient contact, and that's really why I
Yeah,
got into this.
yeah.
but I know you have to be physically, you have to be,
Yeah,
you know. So I was just thinking, you know, which way could I go with it as
up
I,
until 7 or 8 years ago, I was on the floor. I was working. And I was working the youngsters under the table, seriously, yeah. So there's no.
okay, well,
it's
that
all-
was my concern, was the
It's
physical.
all on how you feel and how you feel about yourself. Most, and I'll guarantee you this, most of the therapists will be younger than you.
Oh, yeah, well.
Yeah.
Yeah. At this point in time, most people are younger than me, so.
Exactly, yeah.
You know what I mean? So I
So,
was just trying to look to the future because, you know, I like to work and so I just try to keep up, you know. But if, you know, and I don't really know yet how physical it is because I haven't been in yet. So that's something that I was just a concern I had, you know, as far as like for longevity.
Yeah.
So I guess when I start my clinicals, I'll.
It depends entirely on the site. Some places it's fast paced. Who else was at the University of Florida, the Proton Center?
Oh.
Who else was in Gainesville? Yeah. They're fast. They're extremely fast paced. You have to be fit to keep up with them. But in other sites, they're not quite as fast paced. Who's down in Sanford? Yeah, oh, that's right, you're going when you're finished, yeah. You'll find they're they're not slow, but they're slower paced because it's a smaller center. The bigger centers tend to be fast paced. But the smaller centers aren't quite as fast paced. So it depends on how you feel about yourself, really. I was in Kentucky, in Louisville, in 2005 or 6, something like that. So it wasn't that long ago. And I got called Mama Jane. And some of them weren't that young, much younger than I was, but that was because I was the manager, so they decided to call me Mama Jane. So, this is, I'm gonna have to, okay, that's not working. Okay. So, anyway, it doesn't matter, we don't need it yet. So anyway, that's the symmetry. So I also looked up, and I'll send you this information because this is career growth opportunities for radiation therapists. So the first one is the symmetry. The US Bureau of Labor Statistics is the one that gives pay scales, and this is 2017. And this is a median salary, which means, of course, it's throughout the states. So some will be much more like California and New York, the Northeast, basically, the whole of the Northeast. And some will be less. South Dakota, Minnesota, that type of thing, Florida to a certain extent. So the dosimetrist, the median salary is $98,302. The job growth, so this is, as I said, from 2017. The job growth is 2016 to 2026, and it says 13% job growth. Huh?
What state did you say it was?
It's the US, the whole US. This is from the US Bureau of Labor Statistics. So it's the salary I quote you is an average for the whole US. look up Florida. And education needed is a dosimetry training program, which we'll get into in a minute. Oncologists, you want to be a doctor, a radiation oncologist. Anybody like to tell me what the average salary is as far as the US statistics go?
3 to 4.
Did you look it up, Angel?
I haven't looked it up, but I think
I
it's
was
like
gonna say 4.
3 to 4. Wait.
$250,000. This is the average throughout the US, remember? So 248,675.
Mm.
And the job growth is about 11%. And of course, the education you need is a medical degree in residency. Now, the residency programs, what they normally want you to do is you get your MD, so you're a doctor, but you haven't specialized yet. So what they tend to ask you to do for oncology is do what they call a rotating residency, which means you go through all of the specialties, and then do a radiation oncology residency. So you're looking at maybe 7 or 8 years over the 5 years or 4 years, depending on what your MD program is. It's a long residency. It's a long haul. Okay, so medical physicists. So what do they do? What does a medical physicist do? Well, I'll lead you the little spiel. Radiation therapists are familiar with changing nature of equipment with which they work due to research and development. Some radiation therapists may wish to seek a position in which they're closely involved in its development and study to become a medical physicist. Medical physicists are heavily involved in medical research. They work to develop safer and more accurate radiation and imaging equipment. Some may work to develop computer models for dosage, other treatment information. Medical physicists may also consult directly with physicians regarding radiation output or radionuclides. Most physicists who specialize in research work for hospitals or other healthcare companies possess a master's degree at the very least. Master's in science usually is. And then we go on to do health physics or radiation physics. So that's another step. And the salary that they give you is $134,385. And the job growth approximately is 14%, and they usually require at least a master's. Some departments, they may suggest a doctorate, a PhD in physics. If you're going into, say, medical physics and you're going into a teaching hospital, they probably will require a doctorate. No. Okay. And then, of course, there's management. So some radiation therapists may wish to step out of a clinical role and become more involved in the management of a hospital or outpatient facility. For these professionals, the field of medical and health services management would be a good fit. Health services managers are responsible for recruiting and training employees. They are familiar with laws and regulations concerning healthcare and ensure the facility is following such laws. They must monitor patient data. One can enter this field with a bachelor's degree, however, many employers prefer candidates hold a master's. So you can get a master's in business administration. You can also get you can get a bachelor's in business administration here at FSCJ actually. And you can go ahead and get a master's in business administration, which is the ubiquitous MBA. Or you can get a bachelor's in healthcare administration and go on and get a master's in healthcare administration. And the manager's median salary is roughly the same as the dosimetrist, $98,350. 20% job growth, and education is a bachelor's degree. This is something. Okay, so, any comments? What do you think of those? Anybody leaning towards what you guys were leaning towards the sentence, right? I did take a look at the JCERT programs that will give you a bachelor's in science. There are 4, none of whom you'll be surprised to know are in Florida. One is Bellevue College in Washington State. One is John Patrick University of Health in Indiana. One is University of Texas MD Anderson in Texas, in Houston. And one is Thomas Jefferson University in Pennsylvania.
Right on the Houston one.
All that have bachelor's, so that's the only programs that are JCERT qualified, that do bachelor's degrees. If I can ever get this computer up, I will.
I did find, like, I guess it's
Bachelor's
UNC.
degrees in radiation.
Is that the one in Chapel Hill?
Say again?
UNC, University of North
Yeah.
Carolina. And Emory, I think, have programs for like certification,
Yeah,
but I don't know,
if it's for
I
certificate,
couldn't figure out what the qualifications were for that.
so it's a certificate program,
It must be.
so that's probably a post-baccalaureate program. So you
Okay.
have to have a bachelor's degree before you go
And I
into
would
that.
assume you had to have worked in the field too.
Yeah.
Yeah, so.
Let's try again here.
Yeah.
Yeah,
Ask her
there's
what
also, Chapel Hill, yeah, that's University of
North Carolina, right?
What's
Yeah.
Jason mean?
The
Jason
other
mean?
one that I think, I know that there's one in
So what if we
Melinda.
all sit here listening to her?
Assuming it's
Yeah, you were saying that, I looked that
Yeah.
up, and it looked like there were 2 of them in California. I wasn't sure which one you were talking about.
Yeah, it's Loma Linda.
Loma Linda, I saw that
Loma
one.
Linda, yeah.
Qualified.
That was also, I think, a certification one, right?
Yeah, and again,
So these
which
schools,
means
are
you
they
need a
for radiation
baccalaureate
therapy
degree.
or
And some kind of
Therapy
science.
or
Some
like
kind
all of
health
these?
sciences.
JCERT in Bachelor's of Science in
They're
Radiation
more
Therapy,
likely
right?
to
the
give you,
schools that she listed
to
Bachelor's in
write
radiation or
if
other
you
shit?
are
No, just
in,
the MD
Oh.
Anderson in Houston was dosimetry.
radiation
Oh.
therapy, however.
Yeah.
I think they were 1 year and they were like 5 days a week, like 4 to 8
Yeah,
to 4.
unfortunately, I haven't been able to find any programs that are online.
No, I didn't see any
There
either.
are none that are online,
Definitely dosimetry.
which is very disappointing sometimes.
Yeah,
So as soon as this
moving to
thing
go to
comes up,
school. Good.
I will, get going with it. Anything else that you guys want to know about as far as post exam?
I feel like more of those questions will come from me
As you get used to the, yeah. Yeah. So you're not thinking any further in advance than getting your registry.
I mean, maybe administration has things.
Yeah.
Years.
Yeah, well, obviously they're not gonna give you administration post until you have experience. They usually say 3 years. Sorry,
What about like travel radiation therapy?
travel radiation therapy is a big deal, yeah. They do a lot. However, again, they expect you to have at least a couple of years' experience under your belts, because what they want is someone who can walk into a department and treat. They don't want somebody coming in who looks at the machines and said, I don't know how to run this thing.
I've worked on this.
I've never worked on this before. So what you do is you apply to one of the traveling companies, traveling therapist companies, and they will send you a form, and you have to tell them what you have experience in. Because some departments will say, I want somebody who has experience with varying machines and ARIA, record and verify system. And then you get somebody else who says, or some other department that says, I want someone who has experience with Electa and Mosaic, RMS. So that's basically what they want to know, what kind of experience you have. Now you're straight out of school, you have experience in whatever you've used, but it's not the kind of experience that they want at that point. So they won't entertain you, the companies that organize your travel will not entertain you unless you have at least 2 years experience. And what they'll do is they'll find a spot for you. They will pay your housing, they will pay your travel, and then they will pay you. And it's a lot more than the people in the department are getting, but they sometimes don't pay. You have to make sure that you keep enough money to pay your taxes. They will sometimes pay your health care, but you have to remember that you have to pay all your withholdings out of the money you get. Some departments pay $90 an hour. But with that, you have to remember that you're paying out of pocket for certain things.
Well, if your time is completed in that location, is there any guarantee they're gonna have another location
No.
ready for you? So you
No.
have some possible downtime.
Yeah,
in
yeah.
between.
I used to have a friend who worked with me in, worked for me, I guess. I was a manager, so I guess she worked for me in California. And she worked 6 months out of the year
Weird.
and went off and did something else, did traveling the last 6 months.
That's what my mom does.
Yeah. So yeah, I mean, it's a good system if, one, you like traveling, two, you like to meet new people, three, you're not concerned about being basically thrown in the deep end when you get to the park. Because if they're looking for a locum, which is what we call when we do this travel thing, they badly need somebody because they're understaffed. So you'll get thrown in the deep end. You'll be expected to hit the ground running and do what you need to do. Does that make sense? Okay. So there are 4 or 5 different companies. But you have to remember that you're doing this and you're traveling. So what the companies may say is, where do you want, if you're wanting to travel throughout the country, then we'll do that. But you say, okay, I want to stay in the East Coast. So that means you'll be guaranteed, if you do get a job, it will be on the Eastern Seaboard. Anywhere from South Florida to Maine. Vice versa, if you want to do the West Coast, then it'll be everything off the West Coast. If you say you want to do the middle or the South Coast, then it would be something from Southern California to South Florida or Florida. So you can usually pick and choose. But again, that doesn't guarantee you jobs. The most time the jobs are available are places sometimes where they're having difficulty getting people. So that rules out places where people want to go, which is the coasts. For some reason, lots of people want to go to the Northeast. I'm not sure why, because I don't like the Northeast, but that's beside the point. Some people love the Northeast. Takes all sorts. California, lots of people want to go to California, but there's always jobs in California.
I was just looking at California. One of them was offering $46 an hour.
Yeah,
Yeah,
but think about
the cost of
the
living, yeah.
taxes
Yeah, I
that money get taken off and the cost of living.
Yeah, it's
Whereabouts
insane.
was it in California?
I took a screenshot. I'll look at it. It's because I sent it to my husband. He was like, let's go. And I was like, okay, calm down.
Yeah, you got another year yet, guys, just, you know.
We're all looking at jobs trying to move.
Well, that's okay.
I know, I just want to know, like, where,
Yeah.
when.
Oh, I've scoured the internet.
Yeah, same. I'm trying to not go the wrong direction.
Yeah.
Yeah,
I really
Or
like
rotate the bed when the patient's getting on.
I did, they really like
There-
the patients,
so does UF
especially patients that can't
have
really move
auto
themselves
program?
along.
oh, yeah, yeah, yeah,
So
male, male therapists are always helpful in that,
Like,
yeah.
get on the bed.
Centers
Just
of
let them take
Ventura
advantage.
County.
And then I'm just like, they're gonna kick
Oh,
me
Ventura,
everything.
California.
Yeah,
Yeah.
because they're always
Oh, you're
looking
getting
for
awfully
lifts and
close.
tools and pushes and stuff, but that's all very well, but don't let them take advantage of you.
It's
Yeah,
at
that's
Radiation
close to the
Oncology
elbow.
Centers of Ventura County. $46 an hour, full-time job.
So you know where Ventura County is, don't you?
No,
Just outside of LA.
oh,
It's way too close.
perfect. I can get
Yeah,
all the
it's not
plastic
worth
surgery
it.
I want.
They kept going.
That is, you can afford it after all the taxes and stuff, yeah.
I'll be
Yeah.
able to.
$3,000
Yeah.
mortgage.
So
Yeah,
you
that's
have
not
to be aware
Like
that
88,000.
it looks wonderful
Yeah.
March.
for
18th.
something
May
like
12th.
that that says $46
Although I
an hour, that's a lot of money.
And then the therapist I
Yeah.
was
It's
teaching, she was like, all right, so
Same
you
with
can
the
run into that room and grab
Northeast.
the
That's
pendant because if I
crazy.
get there
That's a
first,
huge
I'm using
difference.
it.
I wonder, I was doing
If you're moving, if you want to move to the
Mhm.
Northeast, New York, for example, or New Jersey,
Yeah.
or wherever, the salaries are higher, the cost of living is higher, and the taxes are higher. So it's a case of, you know, you have to balance things. You go to Wyoming, for example, or Montana, you'll get a job there without any problem. Salaries are lower, but the cost of living is lower. And if you like country, it's beautiful country.
So for travel, how do they do that with the taxes? Do you pay when if you travel and work in California a little bit, and you work in Northeast a little bit? Do you have to split up your tax like that way?
Yep.
Tax for that state for that
Yeah.
amount?
Mhm. Yeah.
Yeah, man.
So that's one of the problems with traveling. The other thing is, remember, you have to have a license for anywhere you go. Your registry is nationwide, so you have no problem with that. It's the licensing. So if you live in Florida or work in Florida, then you need a Florida license. If you get a job in Georgia, you need a Georgia license.
What does it take to get the license? Is that just a matter of paying and
Pay
filling
your
out?
money and getting
Filling
it
out,
back.
but it's no more, not another test.
No, the only one that used to have a test was California, but they've stopped doing that now. There, I think now all of the states need a license. When I worked in Kentucky, we didn't need a license for therapy, but it needed a license for radiography, which was screwed to me, but because most of the people that worked in Kentucky were also X-ray techs. So they had a license already, so I called these guys and said, look, I need a radiation therapy license, because I didn't know any better. And they said, yeah, radiography, and I said, no, radiation therapy. But you have radiography, and I said, no, I don't. Oh, then you don't need a license. And I said, okay. So I was working with people that had licenses because they were radiography first, and then they went into radiation therapy. But I didn't have a license because I was on radiation therapy, which confused the heck out of everybody, management included. They had no idea what I was supposed to do. So yeah, so everybody now, they've changed that, so everybody now has to have a license for all states. So if you go to Alaska, you need an Alaska license. And they're always looking for people in Alaska.
So if
Well,
you be,
actually, you know,
Over the summer.
I'd do that. I'd go there.
it depends. Yeah, I mean, if you,
I mean, it's short term.
That'd be fun.
Then you're good.
yeah. If you,
My sister has a house in Alaska.
I, just for the heck of it, one year when I was looking for a job, I applied for a radiation therapy position in Fairbanks. And it's stuck in the middle and there's nothing around. So I got an interview by phone. I didn't have to go there. And they said, well, the problem is that not a lot of people are used to being alone. And they're worried about being in the middle of nowhere. And I said, that's okay, I grew up in the country, I have no problems with being on my own in the middle of nowhere. Oh, so, you know, they got someone who's from Alaska, so, but, you know, it takes all sorts. People love California. Personally, I don't know why, I think people who live in California are crazy, but, and I worked there for several years, so I know they are crazy. Some people will live in New York and they will never leave New York because they love New York. I
love New
personally will
York.
see what they see in New York, but then that's me.
I love New York.
Because
New York's
I-
amazing.
because
New
of
York's the best.
my jobs, I've always worked in large cities. Because most radiation therapy departments in both Canada and the UK are in large cities. But I've always lived outside of large cities. Because I'm not a city person, I'm a country person. So,
Jacksonville's a city.
you teach money, you teach
yeah,
jobs.
but it's not like a city.
If you wanna stay in Florida, then get a Florida license. And stay in Florida. If you want a big city, you go to Miami. Somewhere else I've never seen. But then,
I don't like Miami.
So if you become a traveling therapist, do you just like up front
get a license for all the states that you'd be willing to visit?
Well, depending on where you want to work. Because it takes a while to work their way through the state bureaucracy. So if you apply for a license where you're gonna work to begin with, like in 2 years, for example, if you wanna stay in Florida for 2 years, then get your Florida license, and then apply to one of the companies that do travel, and say, I wanna stay in the east corridor, so I'll take you from Maine to Florida. And probably as far east, depending on how far east you wanna go, Chicago, somewhere there, then that will count the east. And you would have to have a license for every state that you want to work in. You can specify what states you wanna work in.
And you just do that in the beginning, like once you get that job is when you just up and buy all of the, like, get all of your licenses?
Yeah, well, if you remember, you need at least 2 years before you start applying
Right.
for these travel kits. So you get your Florida license or your Georgia license or wherever you wanna stay for 2 years. And you work for 2 years, and then you tell the people, the travel people that, okay, I wanna work in Florida, Georgia, North and South Carolina, and what else is up there?
Virginia.
You know, if you go up to the Northeast, you don't even have to go up to the Northeast. I mean, if you say that you only want to work in Georgia, Florida, North and South Carolina, that's all you'll get. Now, the chances of getting a job in those 4 states are probably less than if you go further up and go to New Jersey, Philadelphia, Pennsylvania, New York, that area.
I just mean, do you wait until you, like, when they're like, hey, you have a job in North Carolina, do you then get your license, or do you already have it?
It depends on how long it can take up to 6 weeks to get a license. So if you're determined that you want to get a job in each one of those 4 states that we mentioned, then pay your money and get a license for each of these 4 states. Once you've got one license, it's very easy to get another one. Does that make sense? Because in some places it does take 6 weeks or so to get a license. So they may want you tomorrow, or not tomorrow, but within a week. And it can be something like just a month of work there. Or it could be a maternity leave, which may be 3 or 4 months. But if you're, just so that you know, if you're working a travel therapist, you're never gonna get Christmas off unless you specifically ask for it. Because a lot of people want Christmas off and they'll bring in locums to deal with that. So if you want to specify that you need Christmas off, then there's a lot of jobs going to be closed to you. Does that make sense? Okay. So let me get onto the website for
DLC question.
Nothing?
So, let me see. Spell. No, 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 no. What I'm trying to do is get a list of accredited programs here.
Well, it's Friday through Monday.
Program.
We should have Memorial Day off.
Okay,
Wasted.
so let me put this up on the
That got
screen.
ridiculous.
Like suck everything in.
I have to wear those string ones because they're
Me too.
accumulating seats, but here, because of my hips, like they just roll over.
Yeah.
And so when I wear the strings, like they hide right behind it.
Okay. Okay. Let me just, let's see if I can.
Cause it's like weird. I gotta like lean in real far and you can't like see.
Oh.
Okay. Can everybody see this? Yeah, so this is, they're all medical facilities right now. What I did was I looked up JCERT accredited educational programs for. So here is, the first one is Bellevue College, which is Bachelor of Science. Grand Valley State University, which is Grand Rapids, Michigan. They'll give you a master's in science. John Patrick University of Health and Applied Sciences, South Bend, Indiana, Master of Science, Bachelor of Science. Loma Linda, which is in California, Southern California, certificate. Pitt Community College, North Carolina, Southern Illinois University, Carbondale, Illinois, Master of Science. Suffolk University, Boston, Master of Science. Stony Brook University, Stony Brook, New York, certificate post-baccalaureate. Cleveland Clinic Foundation, Ohio, certificate. Houston, MD Anderson, Bachelor of Science. Thomas Jefferson, Bachelor of Science. University of California, Irvine, post-baccalaureate certificate. University of Maryland, certificate. North Carolina Hospitals, that's the one you were probably looking at there.
Yeah.
It says certificate. University of Texas Health Sciences in San Antonio, certificate and lacrosse Wisconsin Master of Science. So let me just see if, see what we get.
Interesting. She's a J cert.
So Bachelor of Science, 22 months. Recognized clinical settings, so there's lots of them, but nobody in, well, this is Washington State, so you can't expect anyone to do anything like in this part of the country. So let's go back. Okay. Okay, so let's do a Master's of Science here. Let's pick someone somewhere that's close.
Do that one for, yeah, that Chapel Hill one.
The Chapel Hill one. So this is Chapel Hill certificate. Let's see what it says. So, 12 months.
Looks like
That's
she
it.
can't walk.
12 months.
But that's, you've gotta be committed to 8 to 4, Monday through Friday.
yeah.
So it is something to think about as far as
Yeah.
financially, it's a,
And it's $500 a year.
100% pass rate, 100% job placement.
yeah, that read
Wow.
that was pretty impressive.
It's a very good job to get into because there's not that many people looking to do it, and it can be difficult to get into it, but once you're in, you're there. So 12 months. So the other one for bachelor's was
22 months.
22 months. But this, it doesn't say why, but I'm presuming it's post-baccalaureate.
Yeah, I think it was.
Yeah.
I think when I looked into it.
It's different. She's not saying bachelor's.
So let's look at
I
something
don't,
else
I
here.
don't know what a baccalaureate is, but it's different.
Let's look at Stony Brook, which is New York.
Is it after your bachelor's? But that means
So again, woo! $7,500.
Oh, it is the same. It's the same thing, but it's a different.
If you're a non-resident, it's free.
Pardon?
It says non-resident 0.
Yeah, I know that.
Are we able to?
Post-baccalaureate. Pardon?
Are we able to look at that ourselves? I was trying to
Yeah,
type it in, but I can't find it.
yeah, yeah. So basically, all you do is you look up JCERT, that's JRCERT, accreditation.org, and / accredited educational programs.
That program only takes 10. Am I seeing that clearly?
Yeah.
The Chapel Hill one only took 2 people.
Oh,
Yeah.
my goodness.
Wow.
So let's look at Loma Linda. See if the person who's in charge of it is still there that I know. Let's see. Yep, still there. Okay. Look at the tuition.
Good grief.
How much was the tuition? I can't see it.
31,000.
That's the one that left.
They
31,777.
only take 6 people.
And how long is it?
It is 15 months.
Yeah.
I mean, whatever, the J will read it.
That's just for the certification.
I think that's where it maxes out too. is
Well, you
like
have,
31
it's
or
probably
51.
post-baccalaureate.
Yeah, there were a lot of,
Bachelor's.
like for me,
Yeah.
didn't have a science bachelor's, so I would have a lot of, prerequisites I'd have to do to even get to the point to
But-
get in it.
Yeah. So basically, the majority of them would be, you would need a bachelor's in some sort of science. Now, if you're a bachelor's in radiation therapy, then that would cover a lot of it.
Does that thing show programs that give you a bachelor's in radiation therapy?
Pardon?
Will that
Yeah.
J-cert show you radiation
Yeah.
therapy?
Yeah, let me go back.
There's some in Georgia.
Now, this is only J-cert accredited, remember, we're not J-cert accredited, okay? So let's look at the J-cert accredited. Okay,
They have
So, so in Georgia, Augusta University, with the Bachelor's in Science,
Savannah. That's not
let's see. 9,801, non-resident, 31,000 people. Okay,
I think they take 20 people.
you take 20, yeah. Completion rate 86%, pass rate of exams 76%, job placement is 87%. Okay, so let's look at this. Oh, shoot, sorry about that. Back to radiation therapy. Oh, hang on a minute, let's just do this. So bachelor's, cut it down a little bit here. There, okay. Here's one, bachelor's in radiation therapy. Oh, Bellarmine, okay. Here's Bellarmine University, Louisville, Kentucky, bachelor's of health science and radiation therapy. The other ones that are bachelor's of health sciences are usually a combination. So let me just see what this one is. 39,350. This is a private university government. 100%, 89%, and 100% placement. 21 months, and they take 15 people. Let's see if there's anything closer to us here. Nothing. Nothing, at least at this JSER.
What's the one in Savannah?
Oh, Savannah, yeah, okay. Savannah. Georgia Southern, okay. So 9,685 and non-resident 29,056. Total capacity 16, Bachelor of Science 22 months, and credential exam 75%, job placement 95%. Well, when you think about it, if you only have 16 people and 3 people fail, that's probably going to be 75%. So it's not as bad as it sounds, but it still looks bad in print.
Those are all the clinical locations you can.
Yeah.
Wow. All the way to South Carolina. That sounds good.
Now, if you were going in with an associate degree, however, there are bachelors online, or the one that I always remember is Weber State, which does an online bachelor's degree in radiation therapy.
Weber with a B? Weber.
Weber, B, Bravo.
Definitely take
Let
another
me
class to fulfill our dreams.
see if I can
While being at these
find
classes.
it.
For sure.
Let's try, oops. Oh, that's spelled. Okay, let's do that. Online. Guys are, okay. Let's try Washburn. Doesn't say what it is, but let me see. Here.
What are didactic choices? What does that mean?
Pardon?
Didactic, second paragraph?
Didactic,
What does that mean?
that means classroom work. So there's didactic and there's clinical.
So class, so you do.
So this is actually a therapy program, same as our certificate program. An applicant must be a graduate of an accredited radiologic technology program, possess a minimum of an associate degree from the institution that's accredited. So it's basically a certificate program for 2 months. So let me go back to Weber State. Yeah.
The recognized clinical setting. Like what that means though.
Yeah, that's what I want. Bachelor's in science. Jesus.
I got 2 candles.
What you do?
So it must be an ERT registered technologist and acceptable equivalent.
If you have a bachelor's of science in radiation therapy, I can still apply to med school.
GPA of 2.0. I think we can do that.
It doesn't matter what you have.
They say they would prefer like just bachelor's of science or biology or something.
So basically, if you had, and this usually is online. I know the last time I looked, it was online.
So at the top there, content may no longer be accurate.
Yeah, well.
There's a link over to the left that says online and continuing education.
To the left?
On the left, you got.
Oh, yeah. Credit programs, firm enrollment, evening classes, WSU online.
And then so that's what is the registry review. Crazy if it's a review or what.
I know.
Yeah, if I remember correctly, the last time I checked, you had to go there for a certain amount of summer classes. So this is the online one. Doesn't look as if they've continued with
Mentions radiation therapy and advanced modality, specialties right there, she's like one box.
I emailed them a few months ago, and they said that you have to complete clinical at one of their specific locations, but they're not.
Sorry, say again?
I emailed them a few months ago to ask about like how you would do your clinical hours. And
Right.
they said you have to go somewhere in
That's-
Utah.
Yeah, that's what that's what I remember. I mean, this is my experience with, trying to work in the university is about 10 years old, so. It's, they were one of the first ones to do a bachelor's in radiation therapy or radiologic sciences. So it looks like now they've decided that you have to complete a radiography program first before they'll do the radiation therapy, so it's the same. I can, keep looking for these. So I think what we'll do is we will, leave that for the moment and do something else.
Where I see that?
Yeah.
I just
Okay.
Googled it. ASRT. Dude, I don't know. I just fucking Googled ARRS and it's a
Okay.
thing. It's a real thing for like radiologists and stuff. I was like, I've never heard of this. That doesn't make sense. It's expensive.
Okay, partial breast irradiation. What is partial
It is
breast
scholarship.
irradiation, guys?
Yeah.
Anybody tell me? Apart from the obvious. So what is partial breast irradiation? So normally if we're treating a breast, how much of the breast do we treat?
The whole one.
The entire breast. That's normally what we treat. Okay, so this is an older slide, this is an older PowerPoint. Mortality declined by 2% per year from 1990 to 2001. The greatest decline in women younger than 50. So 2007, estimated deaths from breast cancer, 40,910. Estimating approximately 180 new patients will be diagnosed. So here is from 1975 to 2004. See, it is risen. Why do you think it's risen? Anybody?
Maybe better, imaging.
Better of a
Are you talking about?
Okay. So, 1975, did we have mammograms?
No.
Did we have mammograms in 1975? Take a guess. Yes or
No, probably
Say
not.
no.
Mm-mm.
We did.
Okay.
We did have mammograms in 1975. But you're right. The techniques and the machines have greatly increased the numbers of lumps that we find. It's a better, machines are better in picking up the lumps.
But I guess that wouldn't affect that data because that's number of women who get breast cancer, right? Not,
Say again?
not deaths. I mean, that's
No,
not,
that's not death.
right,
This
that's
is
just the number. So I don't know if the imaging quality would affect that data.
Well, the incidence rate, yes, it would, because there's no such thing as an incident rate unless somebody actually finds them. You can't have an incidence of something that nobody finds. So if you get better at finding them, then the incidence rate is probably going to go up because you get more people diagnosed. What else could it be?
Did birth control change in the eighties? Did that affect the rates of?
No, not to the same, not to that extent, no. What else? Perhaps education, health education, people being more willing to go in for mammograms and keep going in for mammograms once a year. That also will add to this. So if you've got more people going in for mammograms more often, then there are more people found, or more diagnoses found, right? So that's basically why. Anything else you can think of? No? Okay, let's leave it there. So the increase in incidence from 80 to 87 was largely due to the use of screening mammography. So during that time, the incidence rates of tumors less than 2 centimeters more than doubled, while the rates of tumors greater than 3 centimeters decreased by 27%. Increasing the rate of DCIS has increased more than 7-fold from 1980 to 2001. So they're getting more people diagnosed with DCIS, which is what? What does DCIS stand for? Inside you. So why do you think it would increase so much? Because more people are going for more mammograms early. So the education of women, mostly women obviously, is such that people are doing their own breast examinations, they find a little lump, they're going to get a mammogram. Or you go for a mammogram yearly whether you want it or not. And therefore, more things are being found earlier than ever. That's DCIS. So, this is the current age, the risk of cancer. So 20 we're starting at. 1 in almost 2,000. Time you get to 40, it's 1 in 68. Time you get to 70, it's 1 in 24. And over the lifetime, it's 1 in 8. Some nice hit persons put an arrow there. This is breast, obviously. It's a rather dense breast, but you can see this. This is from a mammogram. And obviously, look at that. Nobody's going to miss that. Breast preservation therapy. So what's breast preservation therapy? Don't overthink it.
Preserving as much healthy tissue.
Got it?
Maybe preserving as much healthy tissue.
It's basically someone who doesn't get a mastectomy. Anything that does not include a mastectomy is breast conservation. So lumpectomy, segmental mastectomy, anything that is less than a mastectomy is breast conservation. So it used to be, so the classic cutoff was 4 centimeters. If you had a lump that was greater than 4 centimeters, the surgeon would say, okay, we're taking the breast. And most of the time, the patient had no choice. This is what the doctor said, this is what all the doctors say. Now, of course, we have a choice. Nowadays, the National Cancer Institute says 5 centimeters. We can probably get a decent cosmetic result in the breast. Of course, their idea of decent cosmetic result and your idea of decent cosmetic result may be two entirely different things, but it's there. Multicentric tumors can be excised in a single specimen with clear margins, and the imaging shows no other suspicious lesions. The patient is still a candidate. What does it mean by multicentric tumors? Anybody? Multicentric tumors. What would that be? Yeah, so one of these days I'm going to go to myself. So, breast, right? Oops, that's right. I'm going to break my leg. So here you have the breast. Here you have the breast. So if you have a tumor here, and a tumor here, and a tumor here, are you going to be able to get that off, all of these off in one area, one segment? No, you're not. So if you have a tumor here, and a tumor here, and a tumor here, yeah, you can take them all out in one. But normally, if you have what they call a multicentric, it was usually a case of, sorry, you have to do a mastectomy. Because if you have a tumor here, and a tumor here, and a tumor here, there's nothing you can do, you have to have 3. And age. The guidelines, 2008, states that women less than 35 have a relative contraindication. But and prior checks, XRT and pregnancy are absolute contraindications while active connective tissue disease, especially lupus, or scleroderma, are relative contraindications. So if you've had prior treatment and or are pregnant, then yeah, mastectomy. Because you really don't want to give a pregnant lady chemo or radiation if you can possibly help it. Radiation I've done in a pregnant woman, but it's tricky. Chemo, they will never do it. So you either have to wait full term or you have to take the baby, take the fetus. There's no other way to do it, unfortunately. So again, this is 2008. So only 86% of women treated with preserving surgery received XRT. Women don't receive XRT after preserving surgery because of age, distance, pair, race, or type of hospital, academic, or community. These days, almost everybody who has breast conservation therapy or breast conservation surgery has radiation. Because we found that it enhances it enhances the prognosis. Who doesn't need XRT? Okay. So 4 randomized clinical trials comparing lumpectomy to lumpectomy plus XRT. All trials showed an improvement in local control with the addition of XRT. All trials showed no difference in overall survival between 2 arms. Trials had varied in terms of surgery and tumor size allowed. So these days, everybody who has a lumpectomy has some type of radiation. So here's the clinical trials. So the NSABP, which is a trial for purely breast. So 1,256 patients, follow up 20 years. Tumor size was less than 4 centimeters. No margins, plus chemo. Uppsala, which is, I believe, in Sweden, 381. Follow up 5 years, tumor size is less than 2 centimeter margins, no chemo. Ontario, 837, that was this marker, PNH. 5 years, less than 4 centimeters, 0.5 to 1 centimeter margins, no chemo. And Milan, Italy is 394, less than 4 years, tumor size less than 2.5, and no margins, and we had chemo. So, again, NSABP. So, this is the number of patients with no radiation, the number of patients with radiation. Survival, no XRT. Survival with XRT. Uppsala, 18 and 2, 90 and 91. Ontario 85 and 87, and Milan didn't show anything. So margins and tumor size do matter. 2 centimeter tumor treated with a good surgical margin has led approximately a 20% recurrence rate without XRT, not 40%. So radiation cuts down on the recurrence rates. These are all just clinical trials, which we'll go into later. What else can be done instead of whole breast radiation? Hormonal, we can do a better selection of patients, and we can minimize the treatment volume. Who do we give hormones to for breast cancer patients? Which group of breast cancer patients do we give hormones to on a routine basis? Anybody? Postmenopausal ladies. So anyone who's perimenopausal or postmenopausal would tend to get hormones. Does anybody remember the name of the hormone drug that we tend to use? Estradiol? No.
I thought at some point we said that they didn't want to do hormones anymore or that they were having issues with it, that they were higher risk of some sort.
The higher, well, yeah, you basically you have a choice. You either cure your breast cancer and have a higher rate of ovarian cancer and endometrial cancer, or vice versa. The drug is called tamoxifen. That's the most common one. But there are give and take on anything. So randomize patients to XRT, tamoxifen, or XRT, and 1 to XRT, 1 to tamoxifen, or 1 to XRT plus tamoxifen. So XRT was still working in this select group at 8 years, with tamoxifen equals 16%, with XRT 9%, with XRT and tamoxifen 3%. So that is the recurrence rate. So partial breast irradiation. So what that is, okay, what that is a small area treated in a short period of time, 1 week usually. Then we can do that on a lot more patients. However, there is a protocol for these. Majority of recurrences seen in those patients not receiving XRT occurs at or near tumor bed. So the rest of the breast may not need treatment. Treating less of the breast may produce fewer side effects, specifically pain and fatigue. So if it's a choice between 4 to 6 weeks of daily treatment and 1 month, 1 week, twice a day, Monday through Friday, most people, I would imagine, would choose 1 week. However, there is a protocol, and there's only certain patients for it that need to cover this. So Several methods now available. So this is partial breast, brachytherapy, 3D conformal, intraoperative, or protons. You can do partial breast radiation therapy with, instead of doing the whole breast, you can do small fields with a normal treatment area.
What's the difference between 3D conformal and IMRT?
IMRT is a type of 3D conformal, but it's more, conformal than 3D. We'll get to that later on.
Okay.
Okay. The 3D conformal usually doesn't use the MLCs to give different doses to different areas, where IMRT does. That's basically what it is. So initial experience was with interstitial brachytherapy, either HDR or LDR. Target volume is the tumor cavity plus 1 centimeter, and treatment is given twice daily of 3.4 gray per treatment. Somebody give me that in centigrade. What's 340 per treatment. So you're doing this twice a day, and you're getting 340 centigrade per treatment. So 340 times 10 gives you what? 3,000, what?
3,400?
3,400 in 10 treatments over 5 days. So, okay. So, Oshna, which is New Orleans, or excuse me, Louisiana. 26 patients, follow up 20 months. Breast treatment, 75 prosthesis. Ontario, this is HDR. Ontario HDR, 39, 20, 2.6. Prosthesis. Boschner LDR, 26, 21, and 78. Beaumont LDR, 120, 82 months, 1 and 91. And Beaumont external, 22, 20, 0, and 100. So what is that? Interstitial brachytherapy with HDR or LDR. Then you have intercavitary brachytherapy with mammocytes. And intraoperative electron beam therapy on 3D conformal and protons. So here is interstitial. So the catheters go in, the catheter tip, basically they have a button on the end so that the catheter can't pull out. You see here? There's your scar from the lumpectomy. And these leads go to a HDR machine.
I'm assuming all those are put in during the lumpectomy?
No,
No?
no,
How do they put those in?
in surgery.
So they have to go back into surgery
Yeah.
after the lumpectomy?
Or they're done, sometimes they're done under, not local anesthetic, but sort of twilight sleep in the doctor's office. So catheters are placed intraoperatively or later using 2 planes. So you see there's several different different areas here. And they're all around this area. Typical doses with HDR, 30 to 36 gray, and LDR 45 to 60 gray. Treatment delivered over 1 week. So these things are put in, the patient comes in, they stay with her. The patient comes in, she is attached to the HDR machine. Treatment is given, she goes home and comes in. She's an outpatient. For HDR and LDR takes a little longer, so she may be an inpatient for this, for LDR. So LDR takes a little longer. Difficulties, very user dependent, especially on number of cases performed. Toxicity increases over time. Telangiectasia and fat necrosis, while others stabilize. Breast pain and breast edema. Cosmetic results appear to improve over time. So this was a Hungarian trial. Okay. Whole breast, 50 gray, no boost. So this is whole breast, 50 gray with no boost versus partial breast radiation. So 258 patients with median follow-up of 66 months. For partial breast, 69% delivered with HDR, interstitial, which you just saw. 5.2 gray times 7 BID over 4 days. For the others, electron being used, 50 gray in 2 gray fractions. Electron being, oh, okay. No lobular carcinoma included. 96 had margins greater than 2 millimeters, 95% were less than 2 centimeters, and 94% were node negative. In the PBI arm, 63% were grade 1, while in whole breast, 50% were grade 1. So, whole breast, 1.5%, marginal, okay, 2.3% TBI. So excellent, good cosmesis, 65% photons, 81% HDR, electron being 70%, not surprised. So 65% were treated with photons, 52% were treated with cobalt. 70% were treated with electron beam, and 81% HDR. Fair to poor prognosis or cosmesis, 24% photons, 48% cobalt, 19% HDR, and 30% electron. Fat necrosis, grade 2 to 4, 49% in the whole breast, 10% HDR, and 8% electron. Okay. So this is the mammocyte. So balloon is placed in the surgical cavity, and that one is usually done when you're doing the lumpectomy. So this thing is placed, obviously the balloon is not blown up when it's pushed in, but then it's blown up. Balloon is available in spherical or elliptical shapes. Balloon sizes are 4 to 5 centimeters, and 10 fractions given in 5 days to about 34 gray. 5 days, 10 treatments, BID. And this is attached to the HDR machine. And the treatment is given.
So what's in the body?
Pardon?
What's inside the
This,
whole, the metal piece too, or just?
this, it's not metal,
Oh,
it's plastic.
oh, so that is inside the breast.
That all you can see out this is collapsed.
How much to limit?
The surgeon puts this into the lumpectomy cavity, and then the balloon is expanded.
Yeah.
And all
Where is
you
it on the
see
image?
on the patient
So
is from the white up.
Okay,
So
Gold.
it's sort of outside the body.
I see what you're
This little white
saying.
thing is outside the body.
and that stays on them for the whole
And
5
that
days.
stays in them for the whole 5 days.
The balloon fills the air or liquid?
It's usually saline or air, depending on how they do it. And then what happens is that it's attached to the HDR, and 1 or 2 radioactive pellets are pushed in here, and they treat lumpectomy.
And that's every day, they push 1 or 2.
Twice a day, 5 days.
And so then to remove that, they have to go back into surgery
No.
again? How
It's
does
just,
it-
it's just, the balloon is collapsed and,
But the pellets are still in there, right?
pardon?
Are the pellets still
Oh,
in
no,
there?
no, they get, it's HDR, so they get taken out, then they go,
Okay, that's what I was confused
it's
about,
HDR, so they're pushed in
pulled out.
and then pulled out,
That's-
or at least the pellets are pulled out.
Okay.
So at the end of the 10 day, or the end of the 5 treatments or 10 treatments, the, usually the radiation oncologist just collapses the balloon and pulls it out, and it's basically a Band-Aid goes on top, and the patient gets sent home. But for the time of treatment, this is outside of the body, this part. It's actually, oh, here we go. So balloon must conform to the cavity shape without air gaps. Device implanted in approximately 10 to 15% of patients. So this is the cavity, you can see here. And this is the isonose lines. Ideal is to have 7 millimeter between the balloon and the skin to decrease the risk of erythema, and very dependent on surgical placement. So if you have a lumpectomy which is close to the surface of the skin, then maybe the mammocyte is not the best thing to do. If it's further deep, then yes. So you have to have about 7 millimeters, which is, but that's not, between the lumpectomy and the skin. Otherwise you get erythema and you don't really want that. But it's actually a neat way to do it. What normally happens is that the patient is brought in for a CT on the Friday. And the CT is done with the balloon in place. It's expanded so that it covers the whole of the opacity, I guess you would call it. And we do the CT scan then. And then planning is done so that the patient is ready to start on Monday morning. And we do Monday morning, Monday afternoon, Tuesday, Wednesday, Thursday, Friday. Friday afternoon, patient's complete. The doctor makes sure that the balloon is down, and he just pulls it out.
But is the pellet that goes in there, I mean, I would think that if the pellet like falls to the bottom.
No, because you can judge where the pellet goes. You can plan where the pellet goes.
So I know during treatment for prostate treatments, but specifically with the balloon, we do it right before treatment. With the balloon for the breast.
Balloon, what do you mean balloon? Oh, that's, you put it in the rectum, you see?
Yes.
Yeah, that's
For
something
treatment.
else entirely.
I just, if they treated with that, would it be the therapist's responsibility to do that, or?
What, the balloon in the rectum?
No, for the rectum, I know,
Yeah.
because I've seen it, but I mean with this balloon in the breast.
This
I've not
balloon in
seen
the
it.
breast is done by the surgeon who does it when he's finished doing the lumpectomy. So he takes out the lumpectomy, he takes out the tumor, and you have this opacity where the tumor was, which is called the lumpectomy opacity, right? And then they put this thing in, he just threads it in, and it sits in the hole what he's made. And when they want to increase this, want to make the balloon rise, then they push either air or liquid into it.
Is it permanent?
No, I just said at the end of treatment, take it out.
Yeah, pay
So-
attention.
Pay attention.
Get your shit together.
No, they take it, they withdraw it on the last treatment, which is usually Friday afternoon. And a piece of Band-Aid is put on top.
So how early before they start the radiation would you have that lumpectomy and that thing inserted? I would assume it's gotta be pretty quickly after they insert it that they start the radiation.
Yeah, yes, it is. It can be as little as a week, 2 weeks, depending on how, because the scar has to heal.
Oh, okay.
Because we don't want the scar not healed. We don't want any infection into the scar.
Okay, so they put it in, they have to let the scar heal, and then you do them.
Couple of weeks, yeah.
Okay,
A week
I
or
was
so.
thinking like a day.
Oh, no,
Okay.
it's not that fast. There's only one thing, or there's really only a couple of things in radiation therapy that has to be done immediately post-surgery. One is a keloid. A keloid, everybody knows what a keloid is. Anybody know what a keloid is?
Yes.
Somebody's nodding their head. Somebody tell me what a keloid is.
The thicker scar tissue.
Yeah, basically when you get cut, you get a scar. With a keloid, with someone who's prone to keloids, the scar tissue keeps on building up and building up and building up. It can be rather nasty. So to treat a keloid, we would send them to a plastic surgeon. He would basically cut off the scar, and we would treat that post-surgery within 24 hours. Most people would say do it the same day. It can be done the same day or the day after, but most people want it done the same day. The other one is something called heriotopic bone, which is roughly the same thing as the keloid, only it's in bone. So usually it's somebody who's had a hip replaced, and the bone continues to grow over the calcification continues to grow. That's another thing that has to be done immediately. Basically, they're brought down from the surgical suite, we treat them. They still have their post-op dressings on. So that's the only things that we would treat immediately after surgery. So William Beaumont showed 2.9% a rate of treatment or with good cosmetic results in 88% of patients. So surgical clips are placed at the time of lumpectomy. This is conformal, 3D conformal, same as you would do for a breast. The clips define the excision cavity, which is expanded by 15 millimeters to get CTV, and 10 millimeters are added to establish the PTV. So in other words, what is the excision cavity? So if we're expanding it, the CTV and then the PTV, what's the excision cavity called? What's the other one that we use? We have a CTV, we have a PTV.
GTV.
Pardon?
GTV, gross tumor volume.
Gross tumor volume, GTV, yeah. So, the excision cavity would be the GTE. Then you expand it by 15 millimeters to the CTE and 10 millimeters to get the PTE. So all of that would be just tiny little thing. So 15 millimeters is 1.5 centimeters, and you have another centimeter. So it could be as little as 3 centimeters you're treating. 10 fractions over 5 days giving 38.5 gray within 6 hours between treatments. So any EID treatments, a minimum 6 hours. You have to, minimum 6 hours. So performed on a standard linear accelerator requires more time for target delineation and planning. Typically plans use 3 to 5 non-coplanar beams. Greater concern for dose to heart, lungs, and contralateral breast in developing treatment plans. More issues with breathing motion and setup uncertainties. So you're treating this area. You're doing tangential fields here. And here's the area you're treating. Here's the area you're treating. Let me see if I can move on this for you. Everybody see that a little better? Okay, so let me just flip off the other lights. Make it nice and dark. Ooh, yeah. So here is your tangential fields. Notice, what's this? Lung. So we've got a little bit of lung. What are these? Ribs, yeah. So you're treating this area here. You've got a little bit of lung, which is okay. You'll have a little bit of lung. So here again, there's your breast here, and you've got this area here. The same here. You've always got this little bit of lung. And here it is in the body. So you've got this. That bit of lung should be no more than 1 centimeter. And that is okay for most patients. Whew. Okay. So, proton beam. So what's so special about proton beams, ladies and gentlemen? What's so special about proton beams?
The Bragg peak.
As it says here, yeah, Bragg peak. So what does that have to do with it?
The beam only goes so far, it stops at a certain point.
Right. So basically, the Bragg peak stops the beam at a certain point. So you're not worried about treating areas beyond where the tumor is. Dose modification to 32, given an increased RBE of protons. 8 fractions delivered over 4 days. So target, this is intraoperative radiation therapy. We'll be dealing with this more as we go along this semester. So intraoperative radiation therapy. This is a target trial, which is comparing whole breast to IORT delivered a single dose of 20 gray from Europe. Intervene photon radiosurgery system, 50 kV X-rays. So what's the idea behind intraoperative radiation therapy? If we were to use it, what's so special about it? Obviously, it can be done in one fraction, which is good. What's so special about it?
Well, I think it'd be easier to locate your target because you've got it open,
Yeah, okay,
you place it right there.
okay. So what's the difficulties with it then? You're treating it in the OR. You've actually got a linear accelerator or an X-ray machine in the OR to treat these with. So
Guess
what?
exposure. Maybe.
Pardon?
I don't know. Exposure?
No, everybody gets out of the way.
Okay, I don't know.
So why doesn't everybody do it? What do we need for a normal X-ray treatment? You're coming in, patients coming in, what do you need?
It's my ringtone too.
You need the physician, right? You need a plan. You need a therapist to do that, to actually carry that plan out. So we're in the OR with a surgeon who's dug in and he's got this breast tumor open. So did he just call down and say hi to his radiation oncology colleague and say, I've got a lady on the table, can you please come up and do some radiation for her? Is that how it works? So tell me how it works. How would it work? Think about it.
You have to schedule everyone to be there.
Yeah. Exactly.
To make a plan for during surgery.
Well, these things, hello, these things are not done at the drop of a hat. They have to be scheduled. So you have to have the surgeon who's there, and obviously all of his OR minions. And then you have to have the radiation oncologist, the physicist, the dosimetrist, and maybe radiation therapist to push the button. So all of that has to be scheduled. So a trial has enrolled 900 patients, with a target of 2,200. Wow. So the problem, margin status, with delivery of treatment at the time of lumpectomy may have persistent positive margins. If you're doing the treatment at the same time you do the surgery, you have no idea of whether there's positive margins around unless you do what's called a frozen section. Anybody ever heard of a frozen section? Frozen section is when they take a piece of, for example, what they think is tumor, they send it to the pathologist, keep the patient on the bed. The pathologist looks at it under the microscope and says, yeah, we have a squamous cell carcinoma, or we have a ductal carcinoma. You can take it out. Or you haven't got negative margins, you have to give me some more. That is what they call a frozen section. That is done while the patient is on bed. But with IORT, you don't often get that. You're doing it immediately you have the surgery done. So, less than 3 3 centimeters. Negative margins, 2 millimeters or more. Has to be node negative, has to be invasive ductal carcinoma or BCIS, and they usually are older women, older than 45. So I'm going to stop here because we've run out of time. We'll continue this next week.